morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences of the ACNS webinars in different parts of the world. Welcome back to yet another edition of ACNS webinars. The speaker for the first session of today's webinar is our honored guest and senior faculty from the USA, Professor Isabella Germano. Professor Germano is the director of the Mount Sinai Comprehensive Brain Tumor Program, and she is also the vice chair for diversity and inclusion and co-director of the radiosurgery program. Dr. Germano's specialty includes brain tumors, computer-assisted image-guided neurosurgery, epilepsy surgery, neuro-oncology, and radiosurgery. She is one of the pioneers of computer-assisted image-guided surgery, and she is active in National Neurosurgery Organization. Dr. Germano has served an executive committee member of the CNS and as a member of board of directors of the ANS, as an executive member of the ANS-CNS Joint Section on Tumors, and as a scientific program member of the ANS-CNS and American Epilepsy Society. For the past 5 years, she has directed a course, Advanced Techniques in Image-Guided Brain and Spine Surgery, for neurosurgeons from around the country. We are extremely honored to have her today as a speaker at our webinars, and today she'll be talking about advances in the management of glioblastomas. The speaker for the second session of today is our honored guest from the United Kingdom, Professor Daniel Walsh. Professor Walsh is a consultant neurosurgeon visiting clinical senior lecturer, King's College, London. He has special interest in a wide range of brain and spinal diseases and particular expertise in vascular neurosurgery. Professor Walsh undertook training at the Hammersmith Hospital, National Hospital for Neurology and Neurosurgery, the Institute of Neurological Sciences in Glasgow, and completed a special fellowship in cerebrovascular surgery at the Royal North Shore Hospital in Sydney, Australia. He also undertook a period of research training at the Imperial School of Medicine and the Thrombosis Research Institute in London. He is a South Thames Training Program Director in Neurosurgery and is a member of the National Neurosurgical Selection Panel. He is a reviewer for several international neurosurgical journals and is a member of the editorial panel of 2. He serves as an elected representative of the individual member committee of the EANS. Through the British Neurovascular Group, he has contributed interdisciplinary training in neurovascular surgery and national audit initiatives. We are extremely thankful to him for accepting our invitation to be a speaker at our webinars. Today he will be talking about microsurgical treatment of cranial dural fistulas. The chair for the first session of today's webinar is our distinguished senior faculty from Japan, Professor Yoshitaka Narita. Professor Narita is a professor and head of Department of Neurosurgery and Neuro-Oncology at the National Cancer Center Hospital, Tokyo, Japan. He is a co-chair, Neuro-Oncology Education Committee, WFNS, and the director of the Japan Society of Neuro-Oncology and Japan Neurosurgical Society. He also serves as the head of Committee of Brain Tumor Registry of Japan and the Committee on Guidelines. He also serves as director of the Japan Society of Intraoperative Imaging and Japan Awake Surgery Association. He specializes in the treatment of glioma, malignant brain tumors, neuro-oncology, and molecular biology. We are extremely grateful to him for accepting our invitation to chair the session of Professor Isabella Germano. The chair for the second session of today is our honored guest from Italy, Professor Francesco Tomasello. Professor Tomasello is a senior consultant in neurosurgery at the Humanitas Clinical Institute of Catania. He was the past vice president and president of the Italian Society of Neurosurgery. He was previously a professor of neurosurgery, Department of Neurosciences, Messina, Italy. He is the founder and president of the Italian Network of Innovation and Technologies in Neurosurgery. He was elected as an honorary president of the WFNS by 170 delegates of Neurosurgical Society from all over the world. He was elected as 2018 Vice President, International Society of Neurosurgical Technologies. Professor Tomasello has performed over 8,000 interventions as the first operator covering the entire spectrum of neurosurgical pathologies. He specializes in the treatment of cerebrovascular pathologies, particularly cerebral revascularization techniques. He is also a noted author with over 200 articles in full length on referred and index journals. We are extremely thankful to him for accepting our invitation to chair the session of Professor Daniel Walsh. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kata, I would like to welcome both the speakers and chairs and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Yoshitaka Narita.
Thank you for introducing us, Raja. So I will introduce our first speaker, Professor Isabel Germano from Mount Sinai Hospital. The title of her talk is Advances in Treatment of Patients with Glioblastoma. Please start.
Good morning, Professor Narita. Thank you so much for your introduction. I also would like to thank the organizers for this great opportunity to be here today all together. And I think I am showing now my first slide. And the next slide is really a slide to recognize the leadership of Professor Kato, and therefore, in honor of her ethnicity, I would like to say arigato, and recognize that she is a leader not just in neurosurgery, but in cerebrovascular surgery, and she is really being leading the progress of women involved in neurosurgery. So Professor Kato, thank you for everything that you have done for our field and you continue to do. Here are my disclosures, and none of these are in conflict with the presentation today. I would like to spend the next few minutes or several minutes to talk to you about glioblastoma and what are the advances in this field. So just a brief introduction on this kind of tumor. Brain tumors are estimated to really increase in the future. You see here a slide showing what the number was in 2012, and 10 years later, these numbers are continuing to increase. Primary brain tumors are very aggressive tumors because of their infiltrative nature, and in particular for glioblastoma, there is a limited therapeutic efficacy, even with radiation and chemotherapy, with a average life expectancy that has been changed over the past decade, but is still very limited, as you can see, 15 to 18 months. Here's an MRI showing a very nicely enhancing lesion, and one could think that by taking a crayon or a knife, you can go around the tumor and resect it. And even if we refer to that as a gross total resection, what we see is that around the periphery of this tumor, there already are cells that are infiltrating the brain. And this is why it is difficult to defeat. And the picture on the bottom right is just to remind us that unfortunately, this tumor does affect different people, and there is really no difference in at the present time. We don't really have any way to either prevent it or foresee that that is happening. Here again, just a little bit on the epidemiology, and we can see that there has been a slight increase over the past 5 years. That is slightly more common in men than in women, and there might be some ethnical differences, although now that we provide service to a greater variety of people, at least in the United States, we see that perhaps some of these ethnical differences are not as striking as we thought in the past. So this is something that is in the process of changing. Just as a reminder, most of us trained with this particular classification, which is the old WHO classification that had 4 grades for the astrocytoma tumors, and grade 4 was classified as a glioblastoma. And you can see in this slide here that this biggest slice of the pie for astrocytoma is really a glioblastoma. So it is the most common kind of tumor. Now we know a little bit more about the tumor, and not just the microscopic appearance on histological features, but we do know that it's important to recognize the presence of molecular signature. And so this paper that came out approximately 10 years ago was able to differentiate 4 different types of glioblastomas based on the presence of molecular signature as represented here in the slide. And the reason why those signatures were thought to be important is because they really had a difference in patient outcomes, so much so that it was easily to recognize that for those glioblastoma that had IDH1 mutation, the patients were surviving better. And so here is now the new classification of tumors now, where I put this box right into the punchline, which is that The differences in tumor nomenclature and grading is emphasized by a layer report. And so you see that here, whenever you have a tumor that histologically could possibly fill the criteria of a glioblastoma, but does not have the IDH wild type molecular signature, by definition, it's not longer a glioblastoma, and it gets put into this astrocytoma category because, as we said, the prognosis of those patients is different. So although what I described to you might seem very complicated, I guess that what I'm trying to say is that everything that I am presenting to you today is still based on the old classification, where the glioblastoma patients were all put in the same basket. But as we move forward, and as you can see, this report just came out, we are going to be able to really make a better sense of glioblastoma patients because they are not all on the same basket. And by so doing, I believe that that survival time that I showed you will also change because we are understanding better the molecular signature of these tumors. This last table I wanted to point out to you is showing that beside the IDH wild type, there are also other pathways that are recognized as a characteristic of this tumor. And therefore, even if some of the histological characteristics might be missing, if the molecular signature is there, we can go to that layered report and say that based on the molecular characteristic, this is now considered glioblastoma. So more to come in future years, but for today's presentation, we're all the data derived from the previous, which is really putting all the GBM in one basket. So in the next few slides, I will show you what we have published in the past couple of years that we like to refer to as guidelines. And we think that the guidelines are important to drive our field because they are based on evidence. This is the strength of the guidance. The weaknesses, there are quite a few, and one is that naturally there are always retrospective, right? So in order to construct a guideline, we have to look at a big pile of papers. And as you can see here in evidence-based medicine, the papers are, or the evidence is constructed in 3 grades, and those are strength of evidence. So if you have a case series comparative studies with historical control, that's a class 3 evidence. And if instead you have a randomized control trial, then that is a class 1. Now, how is the guideline prepared? By reviewing all those studies. So you can see that the delay is astronomical because it usually takes, for any of these randomized control trials, it takes 2 or 3 years to be completed, another year to be published, right? So we're talking already about 4 years. And then for us to put all that evidence together and give you the guidelines, it takes another year or so and another year to publish. So when we publish a guideline, by definition, that guideline is already 6 or 7 years old. That being said, it's still important to check how our field is evolving and to be sure that we know up to that point what is the evidence, and that will allow us to continue build more evidence. So based on the evidence that is available, we provide recommendations, and the recommendations have different strengths. And so a level 1 recommendation means that is based on class 1 evidence. The unfortunate scenario in neurosurgery is that there aren't too many of these class 1 randomized control trials. And when it comes to GBM, even more so. But by and large, in neurosurgery, it's kind of difficult to get this class 1 evidence. So if we go up to a class 2, we consider ourselves incredibly lucky, meaning that we consider that that recommendation is really a strong recommendation. So anything that is a level 2, we consider a strong recommendation that really needs to be followed if we want to provide good care to our patients. And so here is the guideline on newly diagnosed glioblastoma that was published a couple of years ago, or a year and a half ago. And in this particular one, we were looking at the effects of cytoreductive surgery for newly diagnosed glioblastoma. And this is an update of a previous guideline, because by request of the Institute of, or requirements of the Institute of Medicine, every 5 years, the guidelines need to be updated, as I said before, because we need to capture the new data. So in this latest version for the newly diagnosed glioblastoma, as you can see, our recommendation is a level 2, so pretty strong recommendation, saying that maximal cytoreductive surgery is recommended in adult patients with suspected newly diagnosed glioblastoma, and that gross total resection is considered the removal of the contrast enhancing tumor, taking into consideration the preservation of neurological function. So in other part of the guidelines, we show that that preservation is incredibly important, so much so that for some subtypes, let's say insular glioblastomas, if you cause a neurological deficit, your advantage in survival is basically not existing anymore. So in the future, when as we are collecting more evidence on the quality of life of our patients, I think that our next guidelines will be able to give even a stronger opinion or recommendation on the fact that that neurological function must be preserved, and that is even more important than having a perfect postoperative MRI. Some of you might be familiar with the concept of supramaximal resection, and that is a concept that kind of makes sense from the very first slide that I showed you, right? So what I showed you is that what I said is you could put a crayon and go around the tumor and remove that white object from the MRI, from the brain, but we know that surrounding it, there are cells that are already infiltrating. So the concept of supramaximal resection arose from that observation. And so why not do a larger resection than the contrast enhancement? Well, here we just published that unfortunately there isn't sufficient evidence to make a recommendation about this theory. So for now, it's just a theory, but does not have a substract of evidence. The next guideline here will come out this month. Let's see, this month is March. No, will come out either in April or May. This is the proof. And this one is now for the progressive glioblastoma. And what is a progressive glioblastoma? Progressive glioblastoma is a recurrent glioblastoma. The reason why we prefer to use the word progressing is, again, to be very realistic, because we know that even if we do a gross total resection of a newly diagnosed glioblastoma, we don't eradicate the disease, that the disease is still there. And so sooner or later, it will progress. And so you prefer the word progressing glioblastoma than recurrent, because in reality, this was never really taken out to start with, right? Just to be realistic. In any event, so as you can see, this was a major undertake. Many authors were involved. We reviewed over 8,000 abstracts and over 200 full papers. And again, here, the level 2 recommendation is that cytoreductive surgery is really important for this tumor, and there were more based on the images. So here is an example, right? 68-year-old woman presenting with, she's right-handed, presenting with a left upper extremity weakness and difficulty speaking. You can see the weakness there. This is not a video that will be working when I click on it, but you can see that she has an asymmetry of the lips, and when she's trying to retrieve her words, there is really a significant evidence that she has an expressive aphasia. This is not very difficult to understand why. On the sagittal here, you see the frontal operculum, and although the tumor is not nested within the frontal operculum, there is a significant amount of edema that will interfere with our Broca representation of speech. Additionally, here you can kind of see where central sulcus is, and you can see why there is the motor weakness, because this tumor is nested right in front of the motor cortex, causing that significant amount of swelling on it, hence the neurological deficit. And here's the homunculus, just to remind us where that representation is, and that is exactly where the hand is. And here is the patient in the office after the tumor was resected. I don't shave the hair, so the staples are still under the hair, but you can see that her motor deficit is resolved even as soon as 7 days after surgery. This is 7 days after surgery. And on the postoperative MRI, there is what we call a gross total resection, meaning the resection of the enhancing lesion. So I want to share with you in the next few slides a few principles that I think are important. And again, I think that it's important. I know that there are a lot of young people that are watching this video, and I don't want any of you to go to your professor and say, this is what I watched on YouTube, why don't you do it? Because I think each of us tumor surgeons has their own ways to approach these tumors. So what I'm telling you today is what I think is important to me, but I also want you to be keeping an open mind, and especially to respect your professors, because if they teach you something different, it's because from their experience, there is more to learn. So what you're hearing today is just one person, whereas the guidelines is multiple people, several thousands of abstracts. The next few slides is just me talking to you and sharing what I think is important, okay? So just keep that in mind. So I think that for my practice, the goal of my surgeries are to resect the tumor, but as important as resect the tumor is to preserve the function. And we do know that Aristotle had taught us two concepts that unfortunately the Latins only translated into one, primum non nocere. But what Aristotle told us was the first thing to do when approaching diseases is to do good and then not to hurt. So we have to remember that we need to do good. And to do good is to resect that tumor, right? Because if we were just going trying not to induce a deficit, that's not enough. What we want to do is to do good. We want to resect the tumor as much as we possibly can, but also preserve that function. So I think that one concept that is very important for these kind of surgeries is to minimize the retraction. The brain typically around the GBMs is already edematous, infiltrated, and does not withstand retracting. Here is a picture of a neuron that is stained in red in a pre-apoptotic phase. This is a laboratory experiment that I did during my residency, where I was putting retractors on the mice brain and leaving it for a certain number of minutes. And you can see that within 10 to 15 minutes, those neurons are already suffering. So there is definitely a detrimental effect of retraction on normal brain. These mice did not have, or rats, I think in those days were rats. These animals did not have brain tumors. This is just normal brain, but just the retractor itself causes a pre-apoptotic stage. And so what are the ways that we can decrease the utilization of retraction? And the concept is a debulking option. So what we want to do is deflate the tumor, and by so doing, then we can then remove the inside of the tumor and deflate it so that it's easier to dissect it off from the surrounding brain. How do I do that? I like to use this instrument that is called the Ultrasonic Cavitron Ultrasonic Aspirator, also known as CUSA. And I have a few slides here just to show what it is. It is an instrument that was actually a principle that was discovered at the beginning of the 1900s, when the physicist Lord Rayleigh discovered the effect of cavitation And it was not a neurosurgeon, it was a physicist. And he discovered that while investigating damage to a ship propeller. So nothing to do with our field, right? And he concluded that the collapse of the bubbles created a small jet stream of water, which was responsible for the structural damage. And here he is. And here's the propeller. So what this can do then is create this cavitation in soft tissues. And I will skip this and go to this. And when we apply to water-rich tissues like the brain or the liver, the final effect is the destruction of all the cells, preserving the structures that are rich in collagen and therefore low in water. And therefore this instrument is very, very gentle on blood vessels and nerves because there is less water within it. This is how it's constructed. There is a surgical tip, there is a protective cover, there is a shaft. It comes in different sizes. And what it does is really producing this cavitation. And the cavitation allows us to destroy the tissue, and then that tissue that is cavitated gets aspirated by the instrument. There are two different very important features. One is the tissue select that limits the power of the instrument, and again, allows it to destroy a blood vessel. And then there is a very important other thing that you learn when you use this instrument, and that is that there is an haptic feedback. And so the haptic feedback is that as you're using it, you can feel the difference in consistency of the tissue. And for glioblastoma, it's very important because it allows you to differentiate the bulk of the tumor from the surrounding parenchyma. And these are my settings. Again, this is how I like to use it to really be able to benefit from the haptics. If you put the amplitude to 100, the aspiration to 100, you don't feel anything. It's like a vacuum. But if you keep it at this setting for GBMs, you get that beautiful haptic feedback. And so what that instrument does is allowing us to see a tumor like this, that according to our teaching, we would do a very large craniotomy, put a very large retractor, maybe more than one, right? And resect it. And instead we can use a very small opening, resect the tumor. At the end of the surgery, the MRI shows a gross total resection, and most importantly, the patient is neurologically intact. Another important point to consider when removing tumor is working in the eloquent cortex. So I see by default, because they're referred to me by other surgeons, tumors that are considered inoperable because they are within eloquent cortex. So what is the definition of eloquent? It means that it's brain for which other structures cannot take up function in the event of an injury. And this is a concept that is not just important for brain tumor, but it's also important for epilepsy or arteriovenous malformation. So what are the tools that can help us understanding what is really eloquent? One is functional MRI. However, for brain tumor, there is a very important caveat. First of all, for irrelevant of what pathology we're operating on, we have to remember that the concordance between the functional MRI and the intra-operative cortical stimulation ranges between 60 to 100. So what that means is that there is as great as 40% of false representation of a functional area. In addition to that, the range of accuracy is 5 to 15 millimeters. So for tumor surgery, 15 millimeters is huge, right? And the reason why for tumor surgery, this is even more inaccurate is because the functional MRI is based on the Bold effect, which is really the extraction of oxy and deoxyhemoglobin, and that is altered by the presence of the tumor. So just keep that in mind when you do your functional MRIs on patients that have brain tumors, that unless you yourself are already familiar in your own setting, what is that concordance, you might be getting information that is not helpful, in fact, is misleading. The other thing that we can use to understand eloquent areas is tractography or DTI. And what is DTI? Well, DTI is based on isotropic and anisotropic effects on the MRI. And again, it is a mathematical calculation. And the potential contribution is to say that you recognize those white matter tracts, and therefore you avoid them during tumor surgery. And here is a glioblastoma with the corticospinal tract that is wrapped around it. So this looks great. And you go to these meetings and you said, wow, I wish I had those pictures at home. They are so helpful. I can import them in my navigation. But here is the caveat, right? So Sonia Pujol at the Brigham presented this in 2014. So this is not news, but maybe for some of you, you've never seen this. And gave the same DTI data to 10 different centers and asked them based on their own algorithm. Now, if I go back one slide, I just want to be sure that you see that this is rendered on this algorithm, right? So it's a mathematical algorithm. So she's giving the same images to render based on each of these 10 centers algorithm. And this is the representation of the cortical spinal tract by 10 different centers. So which one do we believe? Is this one a correct representation, or is that one a correct representation? So I think that this is a concept that we really need to absorb and to be humble, to understand that whatever our neuroradiology team is giving us, unless we have an intraoperative validation, it's really meaningless. And in fact, it can contribute to injure our patients. So brain mapping. Right? So what is brain mapping? It's the combined use of stimulation mapping technique and cortical spinal tract images to provide for glioma surgery. And this was beautifully reviewed in a review article in the recent literature. How do we select patients for brain mapping? I think that first of all, we have to look at age, remembering that if the patient is a child, beside the issues of not collaborating and cooperating for an awake procedure, but the cortex, when you're less than 5-year-old, is not excitable, and therefore somatosensory evoked potentials work, but not direct cortical stimulation. Mental status. If the patient is non-cooperative, if the patient is confused, don't even try, because the results that we'll have will actually be misleading more than helpful. And finally, if the patient already has a neurological deficit, it's not important to do that awake procedure because the information that you will receive will be misleading. So if there is a dense hemiparesis, clearly the stimulation will not be accurate. And same thing when you map speech, if there is already a baseline error that is greater than 25%, your results will not be able to safely guide the surgery. So very important to keep in mind these limitations when you choose the patients to operate on. One more thing that I would like to share with you, and that is when you're using image-guided resection, that unfortunately using it does not preclude us from not performing accurate surgery. And what do I mean by that? What I mean is that when you use the image guidance, and there are multiple different machines that are currently available, you feel that because you have quote unquote computerized assistance, your surgery will be accurate. However, that's not the case. And it's not the case because the brain is shifting. And this is a very good example that shows you where the microscope is focused on a vessel, and you just leave it there for a few minutes and it goes out of focus. And why is that? Just because there is a little bit of CSF that is being drained, and or the entitled PCO2 is changed and causes brain shift. So we published a long time ago what we think is important when using image guidance. And so the first thing that I always say is, if you use image guidance, do not use diuretics and or mannitol, because it's just the opposite of what you want to do. If you use mannitol, you are actually embracing that shift and you're trying to avoid it. So no mannitol. So how can you do surgery without mannitol? You drive the entitled PCO2 to 25 and 26, 25. And that allows you for some brain relaxation without the shift that will occur with the mannitol. Avoid CSF diversion. Clearly, if you're doing a skull-based tumor, you don't have to worry too much about that CSF diversion, because the shift of the tumor attached to the bone will not occur. We are worried about CSF diversion when we're operating in the parenchyma, because then that can cause, will cause shift. And then for those tumors that are large, always demarcate your X, Y, and Z dimensions. And you can do that into with a picket fence technique. And if the tumor is cystic, do not penetrate that cyst until when you have that X, Y, and Z dimensions marked. And so here is a very good example. It's pretty straightforward. It would be really kind of intuitive to say, Dr. Germano told us that we should debulk first, and so let's drain the cyst so we don't retract. Yes and no. That's what I said, but if you really want to know where those margins are, you need to do your picket fence up front. Okay, and so here's a study that we published a long time ago, basically reminding us that when the tumor is of a certain size, and that is 30 cc's, you really need to have some other sort of intraoperative guidance. And we like to use the ultrasounds for GBM, works really well. If you have an intraoperative MRI, clearly that is as good. And some of the 5-ALA or other stains are also good to use. So for cytoreductive surgery, it is important to remark that unfortunately the data is pretty strong for what we call adult patients, right? And then the question is, what does happen when you reach 65 and more? And so in these guidelines that I showed you, published in 2020, we showed that there is still a survival benefit for patients that are 65 years or older, but that is less strong of a recommendation, is a level 3. And why is that? The reason is because it's multifactorial. Let's just say that. So let's just say, look at this, right? Why is 65 chosen as the cutoff for patients being fragile patient or not? It used to be that we were not living quite that long. And so this age, I propose that we need to change as we move forward. But as I explained, the guidelines are based on retrospective data, on data that maybe was prospective, but was done in the past. And I think that it is important. The age is very important as a comorbidity, but there are also other comorbidities. And there are also other factors that can contribute to morbidity, such as the length of surgery and how many of those surgeries do you do. So where do we draw the line? Let's look at this. This is a great picture. This is a great picture showing that the population age 65 and more is incredibly growing. It's not good to see that perhaps we need more children, but it is good to see that for those that are here today, our life expectancy is significantly increased compared to a few years ago. And this is across the board. So it's not just in some areas of the world, but it's really everywhere that this life expectancy is moving. And so globally, the elderly population, which is now considered around 60 years of age, is expected to increase to more than 2 billions in 2050. And some have referred to this as the gray tsunami. And so the sad part is that we are still anchored in the times where 65 was considered of a certain age. And you see that in the United States, for instance, although the age of 65 and greater accounts for 61% of all new cancers and 70% of all the deaths, the clinical trials include only 25% of patients of that age. So the data that we're accruing right now is data that is potentially misleading because none of those patients is represented, or sorry, not none, but 25% of those patients is represented. And even this is one of the meetings, I think was the ACNS meeting that we had in Venice. So I took this from the Vaporetto in Venice, and even in public transportation, the seat is reserved for greater than 70. So the public opinion already changed. It's just as in medicine that we're still stuck to that 65, right? So it is important that we need to continue to grow. And when we look at other tumors, this is, let's see, this is meningioma. You see that actually these tumors occur with a much greater percentage of patients than that are above 65. So it's not just for glioblastoma that this is pertinent, but to a lot of tumor pathologies and even non-tumor pathology. Here is another paper. This was done 10 years ago, showing the difference of percentage operated patients age 70 or more. And you can see that recently there are more patients that require surgery. And you can see also that the mortality, although in past decades, there was increased mortality in patients greater than 70, in more recent year, that's really not supported. And so this is a rationale for making us changing the 65 to 70 and possibly even more. In fact, in this paper that was published by one of our residents, what they showed was that the age greater than 80 is a risk factor for complications. But up to 80, and this was multiple surgical procedure, neurosurgical procedure, not just glioblastoma, it appears that when you balance for comorbidity, there is really no increased mortality. So what about the medical comorbidities? So in the American Society for Anesthesia has these classes here that allow us to really stratify, and therefore we can look at those and stratify our patients of a certain age based on those class, and that will be much more stronger of a predictor than just the age itself. So here, I think we review this, and the surgical mortality, right? So you see here that the postoperative complication rate does increase when you have other comorbidity. In this particular slide, you see that patient with diabetes have more complications and even higher mortality than if they did not. So there is more to the story than just the age and the ASA score, and we can also look at other systemic disorders. So what I suggest is that preoperative risk stratification may enable us to have a more accurate optimization, and by so doing to mitigate the risks of surgery. Now, what about other factors we can also mitigate? So if we know, and this, I apologize, the title is in Italian because I took it from a talk that I gave for the Italian Neurosurgical Society. But what the slide is saying is CNS tumor in the frail patient. So what are the factors that we can mitigate? We can mitigate two things: the length of surgery and how many of these surgeries does the surgeon do. So it has been shown that a 30-minute increment of operative duration increases the odds of mortality by 17%. And this is in patients that are 80 or older. So that's huge, right? So when we operate on somebody that is of a certain age, I would recommend that trying to do the procedure fast and clearly with safety is something that really needs to be our primary goal. And here you see some of the strategies on this paper, really showing that when you do more of the certain procedure, your mortality is less. And what the author showed here in this paper is that if you do a certain number, your mortality is significantly reduced. And this is not just for brain tumors, but has been shown also for vascular and other pathologies. And then there is something else to remember, and that is that surgery done with a knife or with the ultrasonic aspirator is really not the only thing that we as neurosurgeons have to serve our patients. There are also other things such as radiosurgery. So is there an increased morbidity in older patients when we use radiosurgery? And the answer is no, that has never been produced. So for what we know, radiosurgery is safer in the elderly patient, especially those that are at a very high risk, not just because of the age, but because of the ASA stratification and the comorbidity stratification. Do I imply that glioblastoma should be treated with radiosurgery? Please don't make me say that. However, there might be cases that we can consider a radiosurgery boost to a patient that was previously operated for glioblastoma. So we have to keep our mind open. And by the way, we published on this concept of when and if radiosurgery might be indicated for glioblastoma. And then always remember about the parachute experiment that has never been done, right? So sometimes obvious things cannot be done because it's too obvious and it's too dangerous to actually do the trial. And so what about observation? So for glioblastoma, probably this principle is not applicable, but some of the other tumor like a meningioma in somebody that is 70, why not observating? Transfusion, emergency operation, and weight loss are also predictor of increased morbidity. And so if you can avoid emergent operation, and this was particularly true during COVID, where unfortunately a lot of patients did not have access to the hospital, they presented in as an emergency, and that clearly was detrimental to their factor. And here is the slide I was referring to before, showing that for many pathologies has been shown that if you, the annual surgery volume really has a significant impact on the operative mortality and also morbidity. And so let me then conclude here because we're reaching the end of the hour and there might be some questions, saying that our profession is one that I really I'm passionate about, and I'm also passionate about sharing all the great aspects of this with our children. And with the help of many neurosurgeons during COVID, we created this book that is free of charge. Professor Kato translated it in Japanese for us. There are 12 other languages. So I encourage you to go online, download it, and share it with your children. And I wanted to thank you for giving me the opportunity to share the slides with you. And I'm looking forward to your questions.
Thank you for nice presentation. So the number of older patients are still increasing. The median age of glioblastoma patients in Japan is 68 years. So regarding to the first case you presented today, the patient has a left frontal lobe glioblastoma. Did you do awake surgery for her?
Yeah, sorry, some of the slides didn't click. So for her, I didn't do awake, but I did mapping with somatosensory potential. And the reason why I did that is because anatomically, this tumor was not against, was not involving BRCA, was abutting it. So by doing SSCP, I was able to map the central sulcus and to confirm that this tumor was indeed right in the BRCA's areas 4S and distant from the BRCA's area. The other reason why awake surgery was not indicated in this patient is because her naming error was already greater than 25%. So her expressive deficit was already quite significant. But again, as we recognize from the MRI, it was not because the tumor was within the area, was because of the edema.
Okay. And one of the recent topics is that flarectomy around main enhancing region around glioblastoma. Those procedures might improve the survival of patients. Do you try to resect flare high region around an enhancing region?
Yeah, as I said, in our guidelines, we were not able to find that this really corresponds to increased survival and or increased outcome. So we're not quite able to provide that is a recommended technique to use. That said, I do respect people that collect the data, and perhaps by so doing, we will be able to then understand whether or not this concept is not just a theory, but is backed up by real data. So I think that groups like your group that is documenting this and publishing it is to be applauded, because it might change our paradigm as we move forward.
Okay. Are there any questions for her from the audience? Professor Tomasero.
Yes, Professor.
Isabel, I appreciated very much your slides focusing on limitations of MR tractography in treatment of intracerebral lesions or intracerebral gliomas. I used since several times the tractography achieved by transcranial magnetic stimulation. The difference is, in my opinion, very important, because you can have a somatotopic tractography because you stimulate directly the motor neurons of the motor cortex, and you can have different tracks for arm, for leg, and so on. So this, of course, as you told really in an excellent way, does not avoid the intraoperative brain mapping, which is very important. And this is my first comment. The second comment is about ultrasound, intraoperative ultrasound. I completely agree with your statements, because intraoperative ultrasound of course requires a long learning curve, as we know, but it provides a real-time imaging and is less economic, less time-consuming in comparison with the intraoperative MR. So I think that it is an important message, especially for many countries in the world. On the role of ultrasound, I would like to hear your your opinions on this subject, which is very important. And the last comment, I completely agree with you that Karnofsky and comorbidity for elderly patients with glioblastomas or meningiomas. I performed an overview of my cases during my life. Is more important than age in deciding if you have to operate or not an elderly patient. I congratulate you for this very nice presentation that I am sure we appreciated and will be appreciated by young people around the world. Thank you so much, Isabel.
Thank you, Professor Tomasello. Yes, I think that the ultrasounds for resection of glioblastomas or metastatic disease, it's a very nice technique. I think, just like you said, it's important to grow that learning curve, that learning experience, but ultimately it's pretty straightforward, and it can really facilitate real-time intraoperative understanding. I feel that when you combine the two, the navigation with the ultrasound, you have the best of two worlds, because you can overlap the images and you can have even a better sense of what you're doing. But when resources are limited, I think if you have to choose between the navigator and the ultrasound, probably the ultrasound is the one to have, not just because economically is the one that is the most affordable, but it is the one that really allows you intraoperatively to see what your resection is all about. You already emphasized, and I need to emphasize it one more time, it really takes time to understand those images, and it is very important to know how to use it, because once again, if you don't, then you can be misled by the images.
Thank you very much. Well, may I ask Professor Germano one question? First of all, let me congratulate you and thank you for bringing out such lots of information within such a short time. It was very nice to hear about all the guidelines and the accurate settings of CUSA and the elderly. My question is regarding the elderly patients with glioblastoma. As you said, the patients above 65 was set due to a larger public opinion. Well, in India, where I am currently, the settings is bit more low, which is a 60 years. And I would like to recommend one paper which came out from the All India Institute of Medical Sciences in with regard to glioblastoma in 2020 in the neurosurgical focus, and they have mentioned as elder patients at 60 years, and they have brought out this thing which is the frailty index, which they have examined, and they found that it is much more predictor of outcomes and with regard to outcomes of surgery in patients with glioblastoma. So have you ever assessed this index in your set of patients?
No, I am familiar with the paper, but I think we like to do a little bit more holistic review of the patients. And I think that the ASA, it's a very important one. And also the presence of, so the ASA already takes into consideration the comorbidity. The Karnofsky is very important. It needs to also be taken with a grain of salt in the sense that if you see a patient with a neurological deficit, like the very first patient that I showed, her Karnofsky will be lower, right? Just because she does have the neurological deficit. However, when we look at the images, we need to deduct that deficit because we think that with the surgery, we can improve the deficit. So if you use, anytime that you use a score, you always need to make it patient specific. So if that Karnofsky is 70, that patient probably would qualify as 70, right? Hers is a 70 with the potential to become a 90. And so in those schemes that you find published, that elasticity is not within the scheme, but it's something for us as neurosurgeons that's very important to remember, that our surgeries can at times make the patient feel better, not worse. And so we need to factor that in.
Thank you very much. Any questions from my co-host, Dr. Liu Bun Seng?
Thanks, Raja. Thanks, Professor, for explaining about Karnofsky performance scale, as the scale was made for non-ACNS tumor initially, and you are rightly pointed out that the neurological deficit that caused low score may be treated rather than not to treat the patient. I have two main questions to ask Professor. Do you see that any evidence now to still use guided waveform and the new introduction of intraoperative radiotherapy in GBM cases? And regarding do no harm, what's your opinion regarding doing a decompressive craniectomy for recurrent GBM, which we think that may not be resectable. Are we doing harm or doing better, especially those with significant midline shift and deteriorating conscious level? Probably the last question, Professor, if possible. GBM is a subcortical tumor. Do you find any differences between the accuracy in doing a cortical mapping between the cortical and subcortical mapping for these kind of cases? Thank you, Professor.
Wow, this is a lot of questions. So let me just reply to the first one. Intraoperative delivery of radiation therapy. There are a couple of ways in which this can be done. One is to just deliver ionizing radiation with a balloon, and the other one is silicium tiles. And I think that for glioblastoma, there is really no evidence at the present time that either of the two can be beneficial. And that does not mean that trials and or series should not be published. In other words, in order to have that data, we need to collect it, and has not been collected yet. So I think that perhaps the intraoperative delivery of XRT with a balloon is very appealing for glioblastoma, perhaps for those cases that are recurrent. But again, it's always good to do that within a clinical trial. The second one is a decompression for craniectomy for patients with recurrent glioblastoma. And for that one, unfortunately, there has been data that has been collected, and it does not show any benefit for survival and or quality of life. So I think that that is probably not recommendable unless, you know, there is a bigger study that shows the contrary of what I'm just saying, but otherwise it's something that I would not recommend. And then the third was the cortical mapping and the white matter mapping, and that is very important. The two have to be used. If you decide, when you as a surgeon decide to do the mapping, the cortical mapping is not sufficient, and always needs to be coupled with the white matter tract mapping. So the two have to be jointly done. Thank you. Those were great questions.
Thank you.
Thank you very much. So, Professor Takashi Kon has joined us from Japan. Professor Kon, any questions from you?
Thank you. I'm Dr. Takashi Kon from Tokyo, Japan, Showa University. Thank you for very informative lectures. I'd like to ask you one question. As for elderly patients, we perform supratotal resection using 5LA, but the border is very hard to distinguish between a vague region, a very thin, tainted region, a very positive region. So we sometimes distinguish between edema and less densities tumor infiltration region. How do you distinguish that region, the border of fiber positive region, according to the color?
Yeah, so it's not straightforward, right? Because, and you can look in the literature too, there are different definition of the color intensity and the color itself, pink versus bright. So again, it is something that is not fully standardized. I don't rely on the 5-ALA for resection. I think it's good to have it as part of your armamentarium. I think that relying on the computer guidance and image guidance is more precise. That said, I think it's good to know how to use all different modalities. But there is really no study that shows exactly where that cutoff is. And in fact, there are numerous studies showing that patients that undergo surgery with 5-ALA and quote unquote resection of the fluorescence patients have a much higher perioperative morbidity. So something to be very aware of, that if you don't want to injure your patients, you need to really understand that there is a limitation.
Thank you. Thank you.
Thank you very much. We indeed had a very interesting talk and so much to learn. I would like to ask Professor Yoshitaka Narita to say the concluding remarks.
Thank you. Thank you for nice lecture. We learned too much, and we will make an effort to make good guideline for surgery. Thank you, Dr. Isabel.
Thank you very much, Professor Isabel Germano and
Thank you.
Professor Yoshitaka Narita, for your time and support for the ACNS webinars.
Thank you very much,
Thank you very
everyone.
much for
Thank
joining.
you.
Thank you very much, Professor Narita. Thank you very much. So we'll move on to the second session, and I would like to invite Professor Francisco Tomasella to say a short introduction and invite Professor Daniel Walsh for his lecture. Professor Tomasella, mic is yours.
Thank you, Dr. Raja. First of all, I would like to thank once again my dear friend, Professor Yoko Kato, and you, Raja, for inviting me for this webinar and for continuing efforts in organization of the ACNS webinars, which are disseminated everywhere in the world. And I think this is a great mission for this society. And I am very delighted to introduce Professor Daniel Walsh, who is a worldwide recognized neurosurgeon, mostly, not exclusively, but mostly involved in neurovascular surgery and beyond, brain tumors, spine, and so on. But his contributions to the neurosurgical literature are well known. But I would like to remind, just introducing him, a paper published on British Medical Journal with Dr. Ruth Mary D'Souza about an overview of recruitment of young neurosurgeons in United Kingdom. This is only a proof of the educational commitment of Professor Daniel Walsh in training programs and residency programs. We are very, very anxious, Professor Walsh, and we are looking forward to hearing your important lecture on a topic that we know more in recent years, the microsurgery of cranial dural arteriovenous fistulas. In my life, I know at beginning this disease, but very little, and probably the new tools for diagnosis and also our attention and knowledge on natural history and results with the different treatment strategies make us more familiar with this disease. But your experience is very important, and I wait for your lecture together with other people attending this webinar. Thank you so much.
Thank you very much. That's an exceptionally kind introduction. I'll just share my first slide, if I may. Hopefully you can see that now.
Yes.
Let me add my thanks to the committee for inviting me to contribute to this series of webinars with neurosurgeons all around the world. If I may just take a moment to tell you a little bit about my part of that world. It's situated at King's College Hospital in central London, or south central London. And we service mostly southeastern London, although often parts of the greater metropolitan area as well, and a large part of southeast England. But we have a referral base well beyond that for elements of our subspecialist practice in neurosurgery, and I'm very privileged there to given that it is one of the largest neuroscience centres we have in the UK, that I get to work as part of one of the busiest neurovascular multidisciplinary teams that we have in our National Health Service. Now, I've very much enjoyed listening to these webinars myself in recent weeks. An example I'm showing here is just one that focused on the creative facets of our our neurosurgeons, and I greatly enjoyed seeing the work of Doctors Bederson and co. And I'm constantly amazed by the range of talents and creativity that we see within our community. You had my colleague Mario Tio from Bristol on recently as well, and he completely neglected to mention that as well as being a very talented young neurosurgeon, he's a wonderful painter as well. So in the spirit of that show and tell, I enjoy medical illustration myself, and as we were recovering from the COVID pandemic, I had the opportunity to contribute a piece of work for the wall of our hospital that was redecorating, and that's shown here and where it currently is with our current registrar trainee and Mo Ugas there on the left, and our current neurovascular fellow Sam Hall from Newcastle in New South Wales, Australia. And I was given a choice of subjects, and I chose an AVM based on a series of patients that I've treated over the years. So given that I make those sort of choices, it probably comes as no surprise to you that when asked what I wanted to talk about today, it inevitably would involve an arteriovenous shunt of some sort. And specifically then we're going to talk about cranial dural arteriovenous fistulae, which I'm going to try and pitch at the level of residence and training in neurosurgery, because as Professor Tomasello said, particularly early in our careers, we can have relatively limited exposure to these sort of diseases, as the endovascular paradigm has developed in their treatment. Microsurgical experience inevitably has become a little harder to come by. And when a neurosurgeon in the early stage of their training sees an angiogram of a dural arteriovenous fistula, it can often look like an incredibly complex problem. But what I hope I'm going to get across to you in the next little while is that this can be simpler than perhaps you currently think. So what is a dural arteriovenous fistula? It's, if we divide cerebrovascular pathologies into those that have arteriovenous shunts and those that do not, it belongs with the arteriovenous shunts. So we see blood flowing directly into the venous system from the arterial system without necessarily passing through a capillary bed or usefully supplying any tissue. And the example shown on the right there is of a petrosal fistula, which is draining into the spinal venous system. The potential for these sort of things to develop comes about in part from the arrangement of the circulation within the nervous system. I find it useful to think of the central nervous system as having an intrinsic and an extrinsic blood supply. Now, the intrinsic blood supply is what we immediately think of in the circle of Willis, the arteries that deliver oxygen directly to the brain and then gets taken away into the venous system, the deep and superficial venous systems. The extrinsic supply comes from a circulation that's primarily designed to irrigate the coverings of the brain, the scalp tissues, the skull, and the dura mater in particular. But there are potential areas of overlap and anastomoses between these two systems. And they're not necessarily visible to us unless pathology is present or we are carrying out an intervention. Our interventional neuroradiology colleagues are aware of these communications because they're a potential source of morbidity for them. For example, carrying out an embolization using the ophthalmic artery. Neurosurgeons who've operated on large ophthalmic aneurysms will be aware that such an aneurysm can happily fill very briskly from the external carotid circulation, even when you have occluded the internal carotid artery. So there are many of these potential anastomoses that are present. A tumor may disclose and recruit supply from some of the intracranial meningeal arteries. And sometimes such arteries are also recruited to arteriovenous shunts. And we'll see examples of those as we go through. There are a large number of such anastomoses, and I've only included a short list there of the major ones, including those that have attracted names that you may have heard of, such as the arteries of Bernasconi and Casanare. And given the audience here today, there will be no problem pronouncing that, but it's sometimes referred to as the Italian artery as well, in Professor Tomasello's honor. And you'll recognize, for example, the PCA communication gives rise to the artery of Davidoff and Schechter. So what's interesting about dural arteriovenous fistulae is that in contrast to glomus type arteriovenous malformations, these are probably acquired lesions. They develop later in life, and they often seem to develop in response to some sort of insult. It's thought currently that probably the most likely initiating factor is thrombosis within vascular channels in the dura. And that then allows pre-existing vascular channels, particularly related to venous sinuses, to become arterialized and provide a route from extracranial to intracranial. There are also hypotheses that suggest ischemia plays a role in inducing new vascular channels, neoangiogenesis in the dural leaflet that may then communicate itself intracranially. But probably, I think the most popular theory currently is that a degree of outflow obstruction brought about by thrombus developing within venous sinuses or large veins results in the enlargement and hypertension within pre-existing vascular channels. So what kinds of diseases might cause such a change? Infections, surgery in the area of these lesions, or trauma of any sort. Patients who have prothrombotic tendencies seem to be slightly overrepresented in this group, people who've suffered cerebral venous sinus thrombosis in the past, for example. In the pediatric population, these are also seen as well. Some association has been suggested with in utero infections, and there are some genetic associations that are linked to AVMs as well. They're seen in HHT and CAMS, for example, and other RASopathies. But one of the difficult things to grasp when you're first looking at the imaging of these lesions is how these vascular channels in dural sinuses come about. You may read a rather confusing radiology report that says that there is only there's retrograde flow in a sinus, yet the sinus appears to be functioning. How could that be? Well, if one looks at the walls of venous sinuses, and this is from a study in pigs, and I hasten to add, I am not the D. Walsh who's authored this study. That's a scientist from the University of Limerick in Ireland. But they've done electron microscopy studies of the walls of porcine venous sinuses. And there's two interesting things that arise from that. There are these pre-existing vascular channels. We sometimes refer to them as vasa vasorum within the walls of the vessels, and other vascular spaces as well, venous ones. But look also at the arrangements of the collagen fibers in the walls of the vessels. In some places along the sinus, it's longitudinal and parallel to the direction of flow in the sinus. But then in other areas, particularly where veins plug into the sinus and more posteriorly, it becomes a little bit more haphazard. And that creates, an intriguing possibility that might be more prone to dissection or easier for a diverted blood flow to make its way through into some other element of the circulation. So once such a communication is established, then the symptoms that it's going to produce are really going to be determined by its architecture. Where is the arterialization occurring, and what are the neurological structures nearby that might be affected by that? So as I said, given that this is an acquired lesion, it presents later in life, usually the 5th and 6th decades. And there's a very, very wide spectrum of symptomatologies, so that the clinician may need to have quite a high index of suspicion to detect some of these. So when it's a brain hemorrhage, an intracranial hemorrhage, well, that can be produced by any high-grade dural arteriovenous fistula, and I will go on to explain what I mean by high-grade. But proximity to, for example, the middle ear may produce pulsatile tinnitus. If the venous system adjacent to the orbit is involved, one may see proptosis, chemosis. We'll see examples of seizures or even obtundation and altered consciousness that, to begin with, seems a bit of a mystery. It can present with ischemic brainstem syndromes or myelopathy, and I'll show you examples of those. But while we're talking about symptoms, I'm just going to take a little aside away from arteriovenous shunts and remind us that one of the commoner presentations that where the diagnosis of a dural arteriovenous fistula is raised is pulsatile tinnitus. I just would like to remind you with this case that venous anomalies that do not have an arteriovenous shunt are probably a more common cause of this symptom than dural AVF. This young lady here is a good example. She was referred to me as having probably a posterior fossa dural AVF. She was in her mid-20s and pregnant when she first got the symptom. She had an MRI which shows some vessels within the cerebellum, but they're not very large, and in fact they're more in keeping with a developmental venous anomaly. But what's worth noting is that there's also quite a large arachnoid granulation, and that arachnoid granulation intrudes into the lateral sinus itself. This lady had noticed that herself that when she pushed on the root of her neck, that the pulsatile tinnitus disappeared. And that's a very discriminating clinical sign for something that is producing turbulent flow within the venous drainage and into the jugular vein. So in fact, this is being caused by the presence of this arachnoid granulation, and the hyperdynamic arrangement that followed her pregnancy has just tipped it over into the point where it's become symptomatic. When her pregnancy completed, as it did successfully without complication, the symptom went away. One does see this sort of problem presenting where it doesn't go away, and there have been case reports of, for example, venous stenting to widen the caliber of sinuses that have apparently been successful. But it's a benign pathology, and it's not associated with the risk of stroke, so far as we know, and useful to distinguish from dural AVF. This is the key point I want to make from an educational point of view. This is a disease of those veins. And if you understand how the venous drainage of one of these shunts, you can design a treatment that will cure it. There are two types of these shunts. There are aggressive ones and non-aggressive ones, bad ones and not so bad ones. And they are whether they're aggressive or not is determined by whether they have cortical venous drainage or not. Where there's a shunt into a venous sinus alone and the cortical veins do not become involved, those are a much lower threat to the patient and sometimes may even be managed conservatively. So if you took away only that from today's talk, that would be the key points. If you're still interested, I'll carry on though, and we can talk about how we classify these clinically. If you're from the United States or in that sphere of influence, you're probably going to be most familiar with this, which is often called the Borden classification system, Borden-Schuchart to give it its full name. And again, it broadly dichotomizes into benign types of fistulas that shunt into a dural sinus and types of fistulas that have either associated cortical venous hypertension as well as dural sinus drainage or straight into the cortical veins themselves, and those are considered aggressive. If you're from Europe or from that sphere, you may more frequently hear about what's called the Conyard classification. And again, this is really double-barreled. Maryland Conyard is the latest iteration of it. It was originally developed from a classification proposed by Jinjan. And the modification was to split up the type 2s in this group still more to allow a little bit more granularity. It can be a little bit daunting when one first looks at it, but essentially, again, cortical venous drainage equals bad. If there's no cortical venous drainage, then it is much less likely to cause a stroke. But the various different strata of this system do allow a little bit more granularity in determining risk of stroke. And refining things still further, Zipfel and colleagues have shown that cortical venous drainage that itself is already producing symptoms is significantly more dangerous or more likely to result in stroke than incidentally discovered cortical venous drainage, which is not producing symptoms. And they've proposed a modification to the classifications based on the presence or absence of symptoms as well. So it's worth bearing that in mind. And the picture here illustrates with an ICG on the right, arterialized veins on the surface of the brain. So the low risk types of fistula that one sees, there's either usually a direct communication into a venous sinus, which continues to function or drain antegradely. A type 2A benign fistula may have retrograde drainage in a vascular channel within its wall. This sinus itself continues to function normally because the blood that's draining out of the brain is progressing down a normal channel that is not there's not back pressure from an arterialized system at the same time in many cases. So those types of shunt are it's not completely without risk of hemorrhage, but it's less than 1% for type 1s and of the order of 1 to 1.5% per annum with type 2s. They're associated with very low risks of mortality. The Conyard types that are higher risk all involve cortical venous drainage. And once one sees cortical venous drainage, the chances of non-hemorrhagic deficit is going up to closer to 7 to 8% per annum, with mortality for hemorrhagic episodes sitting at around 10.5%, and very high risks of rebleeding once that bleeding occurs within 2 weeks of presentation. So in many ways, this has a far more adverse natural history than other cerebrovascular pathologies we may deal with more often, for example, unruptured aneurysms or AVMs. So a high-grade unruptured dural AV fistula really merits a degree of urgency ahead of even those better-known pathologies. The type 4s is probably the highest risk for hemorrhage because the vein is no longer anatomically normal on the cortical surface and it becomes ectatic. Type 5s are different again because they drain directly to the posterior fossa venous system and result in arterialization of the coronal venous plexus on the surface of the spinal cord. So those can present with spinal syndromes as well as brainstem syndromes, and that occasionally leads to confusion in diagnosis. So if we therefore accept that the key to this is working out where the vein is forming, we can then develop a strategy to close that venous collector. If you do that, the arterial irrigation to that shunt will regress. Sometimes with very complex fistulas, you're not necessarily going to abolish every aspect of the shunt. For example, you may go from something like a Conyard 2A plus B, where you have cortical venous drainage, and the best that you can achieve is to downgrade it to a 2A, so that there's still shunting perhaps into a major venous sinus, but you abolish the cortical venous drainage. Even in doing that, you will significantly, as you've seen from the previous slides, I hope, downgrade the chance of stroke or mortality very significantly. And we have broadly two tools to help us do this, to close these veins of interest: endovascular tools and surgical tools. And it really does come down sometimes to being as simple as identifying the final common pathway going into the venous system and closing that. How you get there will be determined by the architecture of the lesion itself. And in the last 20 or 30 years, endovascular techniques have evolved hugely and have become the mainstay of our treatment, particularly for lesions that involve venous sinuses, because usually they're going to have an easier time accessing the vascular channels in the wall of the venous sinus without damaging the sinus or causing a lot of bleeding, compared to a surgical exposure of the same lesion. And they can get there through the arterial system sometimes. They can get through the emboli, through the venous system. If going from the arterial side, you've got, however you've just got to remember, you've got to close the vein, but you have that dural leaflet acting as something of a barrier between the arterial side and the venous side. So liquid embolic agents have been increasingly used to allow penetration into the vein from the arterial side. But there are situations where coils may be appropriate, or balloons, or NCBA glue. There's a lot of tools available, but the goal is always the same: the point disconnection, if possible, of that vein. We occasionally get called on to engage with hybrid treatments, for example, providing endovascular access as surgeons by exposing a vein. And I thought I was going to have an example to show you here today of a patient who had an embolization, but although it didn't completely close the fistula, unfortunately there was some residual fistula, still some cortical drainage, but the access was lost. And we were planning a cut down onto a cerebellar vein to gain access to it for our interventionist, but when we did the control angiogram recently, the whole thing had thrombosed off safely and completely, so it was not necessary. But just occasionally we'll get involved in providing access for endovascular treatments as surgeons. Surgery comes into its own as a means to point disconnect a fistulous vein when the fistula is confined just to the cortical venous system and doesn't involve a sinus. So, but even so, if you do find yourself in a situation where you've run out of endovascular options involving a major venous sinus, these principles are still the same. It becomes about, can you close the vascular channel where the shunt is? Sometimes the safest way to do that will be to simply sacrifice the sinus completely, whether endovascularly or surgically. Very occasionally, we've been called upon to open a vascular channel in the wall of a sinus and pack it off. And obviously that's a more hazardous undertaking than simply cutting a vein. But it can be done in the right and selected circumstances. Happily, not very often. So here's a good example of a case where we would favor endovascular treatment. It's a lateral sinus shunt. You may be able to appreciate that there is antegrade flow still in the sigmoid transverse sinus here. There are multiple routes into what may well just be a vascular channel in the wall of that sinus here, from the occipital circulation, but also via the middle meningeal, external carotid supply here. So that's a nice long straight one. That's the kind of vessel that our radiologists favor to get into something like this. But if you lose access through that route, you may well have other options as an interventional neuroradiologist. That would have presented with tinnitus, pulsatile tinnitus, probably the commonest presentation we see with lateral sinus fistulae. But this is more subtle. You may just be able to appreciate, this patient presented with seizures, but you may just be able to appreciate that there's a degree of hyperemia on the medial temporal lobe here. And it was that appearance that raised a bit of a suspicion that there may be an arteriovenous shunt. It's very subtle, but it was a really good pickup by the doctor who spotted it. And in fact, this is a Conyard 3 dural AVF, which has formed in the convexity dura rather than the skull-based dura. And it is irrigated by a meningeal artery, and it fistulates on the surface of the brain just here. There's a somewhat redundant segment of cortical vein here, And this is a case that you could make arguments for either approach. In the event this patient opted to have endovascular treatment, and that endovascular treatment went well, it would be regarded as safe, and because there's good access to the fistula, and there's a degree of redundancy in the cortical vein. Hopefully that if there is any over-penetration of the embolic agent, then there may not be any adverse consequences. But I would just draw your attention to these images. This is after the procedure. The procedure's gone very well and the patient is absolutely fine. The fistula has been completely closed. But there is, here we're looking at a lateral image, and I want you just to note that long tail there, which is within the afferent artery, the artery used for access. And what's happened is the liquid embolic agent, onyx in this case, has refluxed back along the artery. It's not of consequence here because it's a meningeal convexity vessel. But in a situation such as that lateral sinus, the meningeal vessels running along the skull base may en route to the fistula also irrigate very important structures at the base of the skull. For example, cranial nerves as they're emerging through their foramina at the base of the skull. And the example I've given you here, it just shows that en route along the middle cranial fossa, those meningeal arteries give off a facial arcade to the facial nerve. So if you get reflux, too much reflux along a middle meningeal artery of the type I showed you in that lateral fistula, you can end up with a cranial neuropathy as a complication. And those are things that have to be explained to patients beforehand. And occasionally will be reasons that your radiological colleague may invite you to consult. Things are pretty straightforward when a patient presents with a brain hemorrhage. We know something needs to be done. And at first glance, looking at that CT, you like me would assume it's an anterior communicating artery aneurysm. But you can appreciate even from the CTA that it's not, that there's another vessel here, presumably an arterialized vein adjacent to the arteries at the base of the skull. And we see down here there's a little aneurysm within a tangle of vessels too. So this is an AV shunt of some sort. And in this case, this is an anterior cranial fossa floor fistula irrigated by the anterior ethmoidal arteries that forms this vein. This is the AP view here, so we're looking straight at it, and this vein is running up here. The point of hemorrhage is probably that little varix which has developed. So I've asked the question at the top what grade this is. This is a Cranial grade 4 because of this degree of ectasia, and that's probably the bleeding point. This could have developed ectasia anywhere along this vein. It could have produced symptoms as a result of venous hypertension further along its course. But to cure this, all that's required is that vein needs to be sectioned as it enters the anterior cranial base. And on this occasion, we've done that through a lateral supraorbital mini craniotomy. It's literally as simple as that. You diathermy, in this case, we're putting a temporary clip on, but we diathermy divide the vein, and that resolves the fistula. I will come back to the options for surgical access to these sort of lesions just at the end with a couple of observations. ICG is very nice for demonstrating them. Intraprocedurally, and you can we often put a temporary clip on just to demonstrate the arteriovenous shunt, running the ICG, then removing the clip. This is the same disease, but in a more alarming form. So this, you would be again forgiven for thinking this is a giant aneurysm, but it is just there are clues on the cross-sectional imaging that it may be something else. There's a nice example of lamellar thromboses within this aneurysmal, as it turns out, vein. And the angiogram confirms that it is in fact another anterior cranial base fistula. This one, here we're looking at lateral images, is arising via the anterior falcine artery. So these elements of it are within the falx itself. And in the later venous phase, you can see that there are the thrombosed element probably lies somewhere along there. There's a persistent lumen here, and then there's large veins going distally across the frontal pole, and we see them here. The persistent lumen of a varix here, the distal vein here. And in fact, the stump of the fistula is actually very, very short coming off the falx here. But that's all that's required to close this. And unfortunately, it wasn't possible to access it transarterially. The transvenous route was too tortuous as well. So this becomes a surgical prospect. And of course, we have the advantage then of being able to debulk the varix also. And so we've approached this from an ipsilateral frontal craniotomy. The little stubby fistulous vein is identified relatively easily coming off the falx, and once that is clipped and divided, you can get ahead and open that aneurysm and completely debulk it, which is what we did. That's the distal part of the vein running across the frontal pole here, and the large aneurysm is beneath the frontal cortex. Now, another nice approach to this potentially would have been to come at it from the opposite side. You can divide the afferent falcine afferents at the base of the falx, disconnect it, peel that back, and identify that stump, having effectively devascularized it then. We chose not to go from the opposite side because we wanted a really good access to the aneurysm, which is very large, to get a good quality debulking of it. And that gentleman recovered very well. Middle cranial fossa example. Again, at first glance, it looks like a complicated tangle of vessels, but it can be reduced by studying the angiogram very carefully to being a single point of fistulation coming through the middle cranial fossa floor. This is again a Conyard 4 because it's got aneurysmal degeneration of the draining veins. So this is presented with a hemorrhage. Even if it hadn't, this would be a very high risk lesion that merited treatment. And what we've got to do is identify that vein and cut it. It is as simple as that. And that's what you see here demonstrated on the ICG at the base of the middle fossa floor. Once you divide that abolished the arteriovenous shunt completely. This gentleman has presented with a lateral medullary syndrome. So you can see evidence here of ischemia within the brainstem, and this has been fairly rapidly progressive over a few weeks. And an angiogram demonstrates that he has a Conyard grade 5 dural arteriovenous fistula. So the meningohypophyseal trunk has donated arteries that are irrigating a shunt that arterializes Dandy's vein, and then subsequently the perimedullary circulation around the brain stem itself, and produces this condition. Here's the exact same disease, the exact same architecture, presenting in a different way. This patient is presenting with an ischemic upper spinal cord syndrome. And these get missed. They get interpreted as most likely due to neuroinflammation, for example, or various other non-surgical conditions, so that the investigation of them can be quite prolonged without a good degree of clinical suspicion. You can probably appreciate that there are some vascular prominences on the surface of the cord along the way. Sometimes that will lead to spinal angiography being carried out, but it's really, really important that the internal and external carotid circulations are also interrogated, as anyone will tell you is an important part of a good and complete spinal angiogram. The cranial circulation should be interrogated too. And having identified that, this is all in the middle fossa floor, but the fistulous vein entering the posterior fossa is here. And more often than not, it is Dandy's vein complex. So seen here through a small retrosigmoid craniotomy, just like you would do for microvascular decompression. The vein is arterialized, it's non-functional, it can be closed, divided, the tentorium or the petrous fulgurated, and that will abolish the AV shunt. It does not require a more complex approach from the arterial side. I've seen, for examples of people having surgeries through the middle fossa, transpetrous surgery for exactly this condition. And that's born out of a misunderstanding of what the disease is. It's a disease of the veins. If you close that vein, those arteries will go back into their holes. It's really, really rewarding to see the angiography pre and post op. I said I would come back to talking about ethmoidal fistulas and anterior cranial fistulas a little bit, because they're again, along with the petrosal fistulas, the ones that really lend themselves to surgical treatment. And it's often thought that sometimes a low bifrontal craniotomy or unilateral frontal craniotomy is necessary to access these safely. The trouble with that is it will sometimes transgress, for example, the venous sinuses. Equally, if you're putting a bone flap on the forehead very low down, it can be visible, however much care you take in reconstructing it once all the swelling goes down. So cosmetically, you will sometimes be better off extending that flap out so that the edges of the craniotomy reach the superior temporal line more laterally than making a small box flap on the forehead. But another approach to this that we use quite a lot is to do a higher vertex mini craniotomy. So something farther, so the incision can be in the hairline and more concealed, and the bone flap itself less visible. So there's an example here from Zhang and colleagues who've written about this. In fact, I would say that most of the time the bone flap benefits from being even farther back, because then you get a nice trajectory towards the most anterior part of the ethmoidal recess. Here's an example of a case that lends itself to this sort of approach. This lady had declined an offer of surgery previously because what was described was a large flap opening her frontal sinuses and so on. When it was put to her that wasn't necessarily what you needed to do, she became much more amenable. Again, here we have ethmoidal sinus, very anteriorly situated vein. And you can appreciate that this is where the bone flap sits, behind the hairline, right up at the top. The surgeon's eye view, it almost needs to be longer than it is wider, so that you get that posterior to anterior trajectory that allows you to see very, very nicely down into the ethmoidal recess. Now, you'll have seen an example where I've used lateral supraorbital. You could use a mini pterional approach as well for something down here. And with the benefits of endoscopy, you can look sideways down, so you don't need to be looking straight down to see every aspect of the vein. But sometimes this trajectory is very useful, especially if there are question marks on the angiogram about whether there are also falcine elements to the fistula or potential areas of fistulation more distally along the vein. You can inspect the entire anterior intrahemispheric fissure all the way down to the ethmoid and reassure yourself to that point and address them if you come across them in a way that you couldn't if you're looking under the frontal lobe without a second flap. So that's sort of what I'm saying there. You get some endoscopic images of looking down into the ethmoidal recess from above. You will sometimes have to compromise and use a little bit slightly longer bipolar, for example. And I recommend the use of a lumbar drain to relax the brain, which I think is a really useful adjunct. I'm going to finish up by talking about conservative management, because we touched on it, but low-grade fistulas can be managed conservatively, but I want to introduce a word of warning. These can change over time. They can be dynamic lesions. The annual risk of upgrading for a low-grade fistula is thought to be between 1% and 2%. One of the clues that an architecture might be changing may be an alteration in the symptoms. So for example, a patient who was living with tolerable pulsatile tinnitus, suddenly the tinnitus disappears. I tell those patients to come back and see the doctor again, because we need to reevaluate and just reassure ourselves that there hasn't been a thrombosis that has changed the architecture of the fistula, and make sure it hasn't upgraded. So that, bear that in mind. If symptoms change, reevaluate. A word on radiosurgery. There's very little evidence to support its use in dural AVFs. It has been used successfully for mostly low-grade lateral and cavernous sinus fistulas. But it's at its least effective where there is cortical venous drainage. So when you really need it to work, and you really need it to work relatively soon, of course, there's the lead time before its maximum efficacy. It's not so useful. So we rely on it very, very little with cranial dural AVFs. So in conclusion, then, I'll just reiterate the message that this is a disease of the veins. If you understand the venous drainage, you can design curative endovascular or surgical or hybrid treatments. Low-grade fistulas, you can manage conservatively. The risk of stroke is very low, but you should reevaluate those patients if their symptoms change and prime them to represent. Intractable symptoms may be a reason to treat low-grade fistulas as well, in particular pulsatile tinnitus. And high-grade fistulas have amongst the highest risks of any of the cerebrovascular pathologies we deal with, so merit urgent attention. With that, I'd like to thank you all very much, and wish all the best to my colleagues around the world. Thank you for having me, and I hope it's been of some interest. I particularly want to send my good wishes to colleagues who I've been in contact with in Ukraine at the moment, who are having such a difficult time, and I'm sure we'd all send them our very best wishes and hopes. Thank you.
Thank you very much, Professor Daniel Walsh. It was indeed a very, very interesting presentation. I would like to call upon Professor Tomasello to give his remarks.
Thank you very much, Professor Walsh, for this excellent lecture containing crucial information on this disease, provided from your invaluable experience on this field. And I think that we learned too much today from your experience, because you provided us with some cases, very intriguing cases, because I think that a fistula in each patient is a unicum, because the angio-architecture is completely different case by case. So I appreciate very much information on pathophysiology, on natural history, and on natural history, I can say that you emphasized a very important aspect. If you have a case with the first hemorrhage, the further episode of hemorrhage will be in a high percentage of cases in a very short time. This is an important message, I think. About the role of different treatment strategies. Of course, we see always in the literature that the endovascular is the first line treatment. Anyway, I saw that you highlighted the importance of surgery for ethmoidal and for tentorial petrosal fistulas. But I think that we need to define better the role of surgery in comparison with endovascular. This requires a very close cooperation. I would like to hear your comments on this, between the endovascular operator and the microsurgical operator. So this is, I think, absolutely very important. Otherwise, the indication to one treatment in comparison with another it's decided unilaterally, and this is absolutely not acceptable. And I saw that you have a good, very good collaboration, so you can decide together the best treatment for that patient, individual patient. Another aspect which is very important, I think, is that the a question that I have for you. When you have multiple arterialized veins, what is your important tool to decide what communication you have to interrupt? The ICG video angiography, or for example, I can ask about Doppler flow meter, if is useful or not. I use it sometimes in some spinal fistulas, but I would like to hear your comments on this.
Okay, thank you. You hit the nail absolutely on the head. This is a team game. This is not a solo effort, ever. Yeah. And I would say for the endovascular therapists as well, the people I work with closely tell me that they value having a surgical perspective on the pros and cons. And as somebody who's treated lots of AVMs in your past life, I'm sure, like me, you've spent time in the angio suite with your colleagues. And you unpick the architecture of these lesions alongside them in doing that. Our hybrid colleagues probably have a particularly privileged viewpoint in treating dural AVFs, I think. But I'm not a hybrid, so I work very, very closely with my interventional neuroradiological colleagues to try and unpick the fun of dealing with a complex fistula, or what at first appears to be a complex fistula, is that so often, by studying them carefully, by talking with your interventionalist, microcatheter angiography exploration of shunts, for example, you can, and using newer flat panel 2D angiotomography techniques, for example, you can often reduce this complexity down until you have identified a final vascular channel. And I would say in the majority of cases, if we haven't gotten to that point, if we haven't found a common final pathway, I'm a little bit worried, because I think we're missing something and we're likely to find there's a residual afterwards. And that's more common, I think, than actually coming across truly discrete multiple fistulas, which of course you do see in the setting, particularly of things like CAMS, or I've seen it with long segment sagittal sinus thrombosis as well. Yeah. So I absolutely agree with you on every point there. It is with regard to Doppler. Doppler introduces a degree of subjectivity, a little bit like we were talking about ultrasound earlier. Personally, I sometimes find it a little bit difficult to distinguish, for example, with my ear, between triphasic and biphasic flow, particularly when you've got a very hyperdynamic circulation. And one of the things you'll know as well is that with a very high flow shunt, the change is not always immediate, is it? Things remain congested. You get turbulent flow within baggy veins for a long time, and you're wondering, what are you listening to? Even with ICG, it's not. The nice thing about ICG is if you organize it such that you don't contaminate the veins with contrast early on, but that you identify the fistula, occlude the fistula, and then open it while running the ICG. I think that's the most helpful way of using ICG, and we've published a little bit on that in relation to spinal fistulas as well. So we rely on that more than Doppler. I think you need to be more skilled, as you probably are compared to me, with Doppler ultrasound to really be confident that you have finally closed the fistula.
I thank you for your very complete answer to my questions. I completely agree with you that radiosurgery, I introduced the radiosurgery in Sicily, has a limited role in the treatment of this disease, because also the obliteration is achieved in a very very small percentage of cases, and as you told us, not with the ectatic cortical veins, which are absolutely best treated as aggressive fistula with other means. I would like to remind the contribution, and I am sure that you agree with me, of Asian neurosurgeons to this, to the knowledge of this condition, and also of an Italian group with my great friend Massimo Collice from Milan, who passed away unfortunately very early, who contributed this with a great important series of cases at the beginning of this century. What I think that when we say what's new in neurosurgery, this is a very important news in neurosurgery, because we know better, thanks to you and to other contributors, we know better this condition. We know better how to treat with the collaboration of an interdisciplinary group, and this is our role and our mission for the benefit of our patients. I thank you so much for this important contribution. I enjoyed very much your lecture, which is a very important contribution to our knowledge. Robert, I have to ask if there is any question from the audience.
Any questions from my co-host Libun Singh?
Yeah, thanks, Raja. Thanks, Professor Daniel. I have one question, Professor. Those dura AV fistula with the presence of their draining sinus stenosis, would you think that the treatment needed also for the stenosis in terms of the successful of the obliteration of the fistula and also recurrences, Professor?
I've not really come across recurrences in that setting, you know, purely attributed to the fact that there was a pre-existing stenosis. And of course, the vast majority of people who present with stenosis don't have any symptoms at all. So I think probably the appropriate thing to do is to address the arteriovenous shunt first, and then reevaluate. You may find that if there are persisting symptoms and the AV shunt is gone, that a stenosis or a partial thrombosis might be the explanation for that. And then you're into the world of venous stenting, for example, to try and address that, which is in its infancy, I think would be fair to say. It's getting more popular. I think it's searching for indications. I'm not an interventional neuroradiologist, but my impression is that it's maybe a good idea to deploy things like intraluminal manometry and so on, determine whether there are pressure gradients to try and work out how likely you are to affect any change by deploying an intravascular device in that setting. Of course, there is always the risk that you'll completely occlude the venous drainage as well, isn't there?
Thank you very much, Professor.
Well, thank you very much. We indeed had a very wonderful learning session from Professor Daniel Walsh and Professor Tomasello. Professor Narita is still here, as well as Professor Takashi Kon. We are extremely grateful to both for.
Thank you for a great talk about the Dural AVF. So I'm not so familiar with the vascular syndrome, but we re-study again the classification of Corneal and review the papers and study again. It's a good opportunity for re-review study. Thank you.
Thank you very much. We can hear the concluding remarks from Professor Tomasello.
My final remark is that we have today a very important lectures on two of the most important diseases that neurosurgeons face today. One was on gliomas, and surgery for gliomas has an important role today, probably more than in the past. And the role of microneurosurgery for dural arteriovenous fistulas was really in an excellent way emphasized by Professor Walsh. This is a strong encouragement for young neurosurgeons. So for this reason, I mentioned the paper of Professor Walsh, because our mission is to transfer our knowledge to young people, and they have to let grow this knowledge also in the future. So is very important. These webinars have an important role in this particular time we are living for the growth of our knowledge. So I am very grateful to you for this opportunity, and I would like to emphasize the last message of Professor Walsh, the message in favor of Ukrainian people. This is very important. I don't care about about politics. I care absolutely about peoples which have who have absolutely very great trend to modernity, to change their lives. So this is the important message also at the end, and there is a connection between this message and the history of neurosurgery. Do you agree, Professor Walsh? Absolutely. Thank you so much for this opportunity to speak about this topic.
Thank you very much. We cannot thank you enough, both Professor Daniel Walsh and Professor Francisco Tomasello, for your time and support. We are extremely honored. Well, I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaita. I would like to thank both speakers of today, Professor Isabel Germano and Professor Daniel Walsh, as well as the chairs, Professor Yoshitaka Narita and Professor Francisco Tomasella, for the time and support for the ACNS webinars. So until we all meet on 26th of March, it is bye-bye from all of us. Thank you very much for joining.